Hi everyone, in this video I'll be discussing another topic, that is local anesthesia. So we'll discuss local anesthesia. Local anesthesia. Now, why should we know about local anesthesia? What do you mean by anesthesia? Anesthesia meaning sensation. Anesthesia means absence of sensation. Suppose somebody has a cut on the hand and you want to suture them. Suppose you want to suture, patient will have pain. When he has pain, it doesn't allow you to touch. So you have to anesthetize that area. Now when you anesthetize that area, the pain signal will not go to the brain, patient will not be having any apprehension. Suppose he has pain, he will not allow you to touch. So who carries the signal from the periphery to the brain so fast? The nerves. In the nerves, which ion? Sodium ion. So if I block the sodium ions, I can cause local anesthesia. So let us start with our discussion, local anesthesia. And let me tell you the meaning of anesthesia. So anesthesia means absence of sensation. So anesthesia means sensation. There are two types: the local anesthesia and general anesthesia. What is the difference between these two? What is the difference between local anesthesia and the general anesthesia? Local anesthesia, the site, okay, let me try. In local anesthesia, we will anesthetize the local area. So the local area is anesthetized. For example, you are suturing here, only this area is anesthetized. In the general anesthesia, the whole body is anesthetized. That's the difference. Second important, what is the site of action of drugs? The site of action of the drugs is in the periphery. Here the site of action of the drug is in the center. That is in the brain, CNS. Then the next important thing is, will the patient be conscious? Yes. Patient will be conscious when you are using local anesthesia, but he will not be conscious when you are giving general anesthesia. The next important thing is, when we give anesthesia, should we monitor the vitals? Should we check the BP and all those things? No. Vital monitoring is not required. Vital monitoring is not required, no. But when you give general anesthesia, yes, you have to monitor the vitals. Very, very important. So can you do it in non-cooperative patient? Suppose patient has hurt and is not cooperating for the suturing. Will you do that? No. Non-cooperative patient, can we give local anesthesia? No. But in general anesthesia, you can give for non-cooperative, because when you give anesthesia, you will sleep sedation. So you can give it to them, no problem. Can we do major surgery with local anesthesia? No. But you can do major surgery with general anesthesia, yes. Minor surgery, yes, minor you can do. Minor surgery, yes, you can do. Even you can do minor surgery with general anesthesia, no problem, but preferred is local anesthesia. For suturing and all, if you give anesthesia, there is no need. Okay, minor surgeries. Now, if the patient has poor health conditions, so he may have the fluctuating BP, he may have some other heart disease. Now, which anesthesia is better? In poor health condition, this is better, and general anesthesia is not preferable. Okay, because when you give anesthesia, patient BP will fall down, respiration will fall down. That's why poor health condition, local anesthesia is better. So this is the difference between the local and general anesthesia. Local for local area, general means whole body. Consciousness is there in local anesthesia, no in general anesthesia. Vital monitoring is required in general anesthesia. Non-cooperative patient also you can do that. General you can do for both major and minor. Usually for local we do the minor surgeries, And if the patient is having poor health condition, local is better, general anesthesia is less preferred. But it all depends on the patient factors. Okay, yeah. So once I know these things, let us start our journey of local anesthesia. Let us start our journey of local anesthesia. Now the first local anesthetic that was discovered is a drug by the name cocaine. Now you know what is the mechanism of action of cocaine. Cocaine, if I tell you the mechanism of action, it is known to inhibit the uptake of noradrenaline. So what happens in the sympathetic system? This is the sympathetic synapse. Now you know that neurotransmitter is the noradrenaline. When the noradrenaline is released, it is again taken up back. This uptake is blocked by cocaine. So cocaine has local anesthetic property, correct, but along with that, it also increases the activity of noradrenaline. So it is an indirect sympathomotivating drug. Now what happens when there is cocaine given to the patient? The BP increases, it causes vasoconstriction, and it can increase the heart rate. So these are the problems what the patient will face, because noradrenaline acts on alpha and beta receptors, so patient will develop this. Now what happens to the eye pupil? Cocaine can cause mydriasis. Why? Because of the noradrenaline activity. So this is not used as local anesthetic. It was used as a drug of abuse. Why people abuse cocaine? Because it increases sympathetic activity. So sympathetic means performance is more, they don't feel hungry, they want to party, that's why cocaine was used. Then we came with another drug modifying that is called procaine. But the procaine had a problem, there was decrease in BP with this. So the later anesthetics, they started falling off BP. Now why cocaine causes a rise in BP? Because along with local anesthesia, it also inhibits the uptake of noradrenaline. Then after procaine, what is the commonly used local anesthetic? It is called lignocaine, one of the most commonly used local anesthetic. Okay, so remember, lignocaine is also called by one more name. Any guesses? Yes, it is also called as lidocaine. So a drug has two names. For example, paracetamol has one more name. What is that? Acetaminophen. So lignocaine, another name is lidocaine. So this is the introduction of these drugs. Now, once we know this, let us understand the chemistry of them. Let us understand the chemistry. Local anesthetics chemically are two types. Either they are derived from esters or they are derived from amides. Either they are ester derived or amide derived. So let us understand the difference here. Let me draw a line and let us understand the difference. Now remember, the ester drug example for you is a drug by the name cocaine. The name is cocaine. Then we have procaine, and for that you add chlor, it becomes chlorprocaine. Then we have benzocaine, and we have one more, and that is called tetracaine. Okay sir, fine, but what is this amides? Amides example is lignocaine, also called as lidocaine, lignocaine. Then we have bupivacaine, and prilocaine, and one more is called dibucaine. It is called as dibucaine. Okay sir. Sir, how do I know whether it is ester or amide? Simple, there is a simple trick. What is it? If they have single I in the name, they are esters. If they have double I, lignocaine has 2I, bupivacaine has 2I, prilocaine has 2I, then they are amides. So 2 I's means amides, single I means esters. Now why are we studying them? Now remember, these drugs, esters, are metabolized by metabolized by plasma esterases. I told you in general pharma also, if the drugs are metabolized by esterases, they are very short acting. So these drugs are shorter acting. These are short acting drugs. Okay, let me continue the differences. These are shorter acting. What about these? These are longer acting. They are not metabolized by esterases, but they are metabolized by liver enzymes. So metabolized by liver enzymes, and they are longer acting drugs. And these can produce hypersensitivity reaction, allergy. Hypersensitivity reactions are seen with esters. There is less or no hypersensitivity with amide drugs. Another difference is no plasma protein binding. They don't bind to plasma protein, but when you compare this, they will bind to plasma protein. And remember, lignocaine I have discussed in general pharma also. A basic drug, it binds to. These drugs binds to alpha-1 acid glycoprotein. Alpha-1 acid glycoprotein. So that is the difference between the esters and amide. Simply remember, esters have single I, metabolized by plasma esterases, very short acting, hypersensitivity reaction can be seen. They don't have plasma protein binding. Amides, they have 2I, they are not metabolized by the plasma esterases. They are metabolized by liver enzymes, longer acting. There is less chance of hypersensitivity, but they bind to alpha-1 acid glycoprotein. So once I know the drugs, I should understand the mechanism of action. So I'm asking you, what's the mechanism of action of drugs? So let me explain to you. Local anesthetics, I told you, when there is the cut, signal has to go to the brain, and who will carry faster? Sodium. So their mechanism of action is to block sodium channels. Now the sodium channels occurs in two forms. They block the inactivated sodium channel more than the open state. Now what happens if you block the sodium channel? The signal is not going, so there is decrease in sensation from periphery. So decrease in sensation from periphery. Very good. So what happens if the sensation decreases? And that is what we mean by local anesthesia. So we see the local anesthetic effect. So we see the local anesthetic effect. So that is the mechanism of action. Now you need to remember the sodium channels we have discussed in antiarrhythmics also. The sodium channels occurs in three forms. Right. Now this state is where the M gate is closed, H gate is open. This is called the closed state of sodium channel. Closed means the sodium cannot enter inside. So sodium has to enter through this channel, and the M gate is closed. There are two gates in that, the M gate and H gate. So this is outside the cell and this is inside the cell. So sodium has to enter, but it will not because it is closed. Now after some time, what happens? This gate will open. This is the gate. The M gate will open. The H gate is also open. Then the sodium can enter inside. So that is called the open state. This is the open state of sodium channel. Now after this, it will again become inactive state. So what is that? Let me draw. This is the channel. In this channel, the M gate is still open, but what happens is the H gate comes and closes it. So when that closes, sodium cannot enter because the entry is blocked. And this state is called inactivated state. So this is called inactivated sodium channel. Now from here, the drug the channel will again change to closed and then become open. So this keeps on occurring. So the reason why it is made like this is to make it refractory, otherwise every millisecond the signals will go. So first it will be closed, then open, then inactivated, again it will come to closed. So I told you these local anesthetics, they mainly block the inactivated sodium channel as well as open state of sodium channel. And if sodium doesn't enter, sensation will not go, patient will not have the sensation. That is the meaning of anesthesia. Now if I want to go in detail and tell you what exactly happens in the cell membrane. So this is the cell membrane. This is the cell membrane of the axonal membrane. Now what happens here is, this is the sodium channel. This is the sodium channel. Okay. This is the sodium channel. Now the drug has to go. Now remember, these local anesthetics are basic in nature. The pH in the blood is around 7.4. Inside the cell it is 6.9. So this is in the blood and this is inside the cell. Now when we use the anesthetic, so let me write BH plus, that means BH plus meaning they are ionized. So local anesthetics are ionized. Now what happens? They will release the non-ionized form. So what is the non-ionized form? That is B plus H plus. So let me extend this. The axonal membranes, let me extend this. Okay. So you know that ionized will not cross. So who will cross? It is the non-ionized form which enters inside the cell. Once it enters inside, it is again in the non-ionized form. So it will again become ionized. So it becomes BH plus. So this is the ionized form. And inside the cell, the pH is 6.9. And the ionized form is the one which blocks the sodium channel. Blocks the sodium channel. So the point here to understand is, if the pH is 7.4, if I want to make the drug more and more non-ionized, and the drugs are basic, tell me what should I do with the blood pH? Should I make it more basic or more acidic? Yes, you know the general concept. What is that? If you place basic drug in basic medium, it is more non-ionized. So the blood, if you are making more and more alkaline, what happens? You will get more and more non-ionized form, and the non-ionized form is the one which enters the cell membrane easily. So alkalinity favors the drug onset of action. Clear? So let me explain again. The ionized form will become non-ionized. That is the one which crosses the membrane. Again it becomes ionized and blocks the sodium channel. So this is in detail. So the alkalinity will favor the non-ionized state. So making the blood alkaline will favor the action of local anesthetics. Yes. Now once we know the mechanism of action, once we know the drug, let us understand the pharmacological action. What are the pharmacological actions we see? Pharmacological actions of local anesthetics. What happens if they enter our systemic circulation? When we give local anesthetic, they will act locally, but what happens if they go systemically? First we will understand locally what happens. Locally they produce anesthesia. They produce anesthesia, correct? They produce anesthesia, so that means they decrease all the sensation. Tell me what are the sensations you know of? Pain, temperature, touch, pressure, all those things. Now when we start local anesthesia, which fibers are affected first? So let us write who gets affected first. Order of blockade. Order of blockade. This is taken from K.D. Tripathi. Now the small diameter nerve fibers are affected first, then the large diameter, because it's very difficult to penetrate the large diameters. So that's why small diameter easily they can go and block it. Myelinated fibers are blocked than non-myelinated. So myelinated fibers are easy to penetrate compared to non-myelinated. The types of fibers. So it is the B fiber, then C fiber, then A fiber, in that A delta, and then followed by A alpha, beta and gamma fibers. Now in ANS, motor and sensory, who gets blocked first? It's the ANS, then the sensory, then the motor. So the first to get blocked is autonomic nervous system, then sensory, and then the motor. Now what about the tongue? If you put a local anesthetic in the tongue, who will be lost first? Tongue. The first sensation to be lost is bitter taste. So bitter taste is the one which is lost. Then after bitter taste, what is lost is sweet and sour. And the last to disappear is the salty. So this is how it disappears. So this is the order of blockade. Now when you stop local anesthesia, for example, the local anesthetic effect is gone, then who comes first? It is reverse order. It is reverse order. Let me take an example here. The first to go is ANS, sensory and motor. Now who will come first? Motor will come first, then sensory, then ANS, like that. Again, if I take the tongue, which sensation comes first? Salty, then sweet and sour, and then bitter taste. So that is the meaning of reverse order. Now when we compare the sensory, so who is lost first? In sensory, who is lost first? In sensations, that is the one which we are dealing. The first to go is pain, very very important. We don't want a pain, we want a suture. Then the cold, then the warmth, then the touch, and then pressure. So the first to disappear when we use local anesthetic is pain, that's what we require. But when you stop, what comes first is pressure, then touch, warmth, cold and pain. Yeah, that's the meaning of it. Okay, so we understood the local action. The next important thing is, what do they do in the CVS? What do they do in the CVS? Now in CVS also we have the sodium channels. Now if you block sodium channel in the CVS, these drugs act as myocardial suppressant drugs. They depress the heart. Now if you remember, we have discussed lignocaine, and lignocaine belongs to class 1B antiarrhythmic. So it is a class 1B antiarrhythmic, and where do we use it? We use it to treat ventricular tachycardia. That is lignocaine for you. Now again there is a drug called procainamide. Now procainamide is derived from procaine. You know the local anesthetic procaine, and it belongs to class 1A antiarrhythmic. It's a class 1A antiarrhythmic. But remember, if you are using this local anesthetic at high dose, they themselves can cause arrhythmia. Local anesthetics, they can use to treat arrhythmia, but when you use antiarrhythmic at high dose, they themselves can cause arrhythmia. So if you are using these drugs at high dose, in toxicity of local anesthetic, for example, by chance you give lignocaine high dose IV, then what happens? High dose can itself cause arrhythmias. Now among all these drugs, one drug is highly cardiotoxic. The name is called bupivacaine. So bupivacaine is highly cardiotoxic, so it can have the risk of arrhythmias. Toxicity is very very high with bupivacaine. So lignocaine, procainamide, bupivacaine, these are the applications. So remember, these are all myocardial suppressant drugs. Myocardial suppressant drugs. Now once we know about the heart, let us understand the next system in the blood vessel. In the blood vessel. Now in the blood vessel, what do? They are known to decrease sympathetic outflow. So they can act in the brain and decrease sympathetic outflow, and that can lead to vasodilation, and they decrease the blood pressure. So most of the local anesthetic adverse effect is when you give them systemically, hypotension. But there is an exception. What is that? Cocaine is the only local anesthetic which increases the sympathetic system. So that is called cocaine. So they can ask you in the exam, which is the only local anesthetic which can cause increase in BP, vasoconstriction, and mydriasis. The name is cocaine. This is the only difference. All of them will do hypotension. Very, very important point. So we understood what does it do in the blood vessel. The next one is, what do they do in the CNS? In the CNS, what do they do is, they stimulate the CNS first. CNS stimulation followed by depression, followed by CNS depression. So how do they do that? Number one, first of all, they inhibit the action of GABA. Now you know what is GABA? GABA is an inhibitor neurotransmitter. Now what happens if you inhibit GABA? The CNS becomes excitable. So the CNS becomes excitable. And what happens if CNS is excitable? Patients will have seizures. So you can see seizures in high dose of local anesthetics. So remember, high dose of local anesthetics can lead to arrhythmias and they can lead to seizures. Very, very important point. So we understood the effect of in the CNS. But what is a sign, early sign to tell that the dose of local anesthetics are higher? So there is an early symptom, early neurological symptom to know about local anesthetic overdose, and that is circumoral numbness. Patient will have circumoral numbness. So I will tell the sir, I am not able to feel the parts here. So numbness, he will have numbness here. So that is about in the CNS. What about in RS? Respiratory system. So respiratory system, only when they give it at high dose, they are respiratory depressant. So they depress the respiration. They are respiratory depressants. Okay. So remember these actions. Locally, I told you they are acting as local anesthetic. In the heart, high dose can cause arrhythmias. In the blood vessel, low BP, CNS seizures, and respiratory depressants. So any patient who comes with local anesthetic overdose, so the patient having seizures, you have to manage the seizures, and the seizures are managed with the lorazepam or diazepam can be used. So local anesthetic overdose, patient may develop seizures, so we can use lorazepam or diazepam. Now is there any antidote for this? Yes, we have an antidote, and that is called 20% intralipid. So it is a lipid emulsion which is given IV. So the mechanism is still unknown. How does it work? Mechanism is unknown. So this was recently asked in the exam. What is the antidote for local anesthetic overdose? Yeah. So once we know that, let us understand the individual drugs. Certain individual drugs, what are their specialties? Individual drugs. So the number one, the first one to be discovered is called cocaine. Now cocaine is a naturally occurring one. It is a naturally occurring one. And it is an ester obtained from the plant. And I told you it is not metabolized by the esterases. Usually the esters are metabolized by esterases, but this is metabolized by liver enzymes. So there is an exception. Remember, anything ending with I, one I is what? They are esters and metabolized by esterases, but this is metabolized liver enzymes, not by esterases. So that is one specialty of this. Now other specialty is cocaine. We have abusers. Cocaine is abused. Why it is abused? Because it increases the sympathetic activity. Person want to party, doesn't want to feel hunger, he doesn't want to get tired, so they use it. But usually the abusers will sniff it. It is sniffed through the nose. Now when they sniff it through the nose, they will have nasal perforation. They will have nasal perforation. Now what is the reason? Why will they have nasal perforation? The cocaine sniffers, they have nasal perforation. Why? Can you guess? The reason is simple. It is a vasoconstrictor, cocaine. So what happens if you cause vasoconstriction? Obviously there will be ischemia. So when there is ischemia, the tissue dies, and the tissue dies, it will be thrown out. So there is nasal perforation. So cocaine abusers, if they are sniffing, you will see nasal perforation. So natural occurring one, abused drug, ester, not metabolized by esterases but metabolized liver enzymes, and it can cause nasal perforation. So not a local anesthetic, nowadays we don't use it. Procaine came into the market. It is the first synthetic local anesthetic. Why it is called synthetic? Because we had a natural one, cocaine. Then we synthesized this in the lab, that is procaine. Then we have procaine and benzocaine. Sir, why are you writing that separately? I will tell you. Procaine and benzocaine, these two drugs are metabolized to PABA. They are metabolized to a compound called PABA. Now why are we worried about this, sir? Now PABA is associated with a rare kind of anaphylaxis. So the generated PABA is associated with a rare kind of anaphylaxis, that's why it is important. Then we have another drug called chlorprocaine. The name is chlorprocaine. It is one of the shortest acting local anesthetic. One of the shortest acting local anesthetic, there is a specialty. Then we have prilocaine or prilocaine. Prilocaine is metabolized to a compound called O-tolidine, orthotolidine or O-tolidine. Now why should I know this, sir? This is going to contribute for causing methemoglobinemia. Methemoglobinemia. Now what happens if there is methemoglobinemia? The patient will have cyanotic look. Is there any treatment for this? The treatment is methylene blue. So methylene blue is used to treat methemoglobinemia caused by prilocaine. The reason is O-tolidine. Again, this question had appeared plenty of times in your exams. So we are done with the cocaine, procaine, chlorprocaine, prilocaine, all those things. Then the famous one which we use commonly in the practice, lignocaine. Lignocaine is also called as lidocaine, and it is one of the most commonly used local anesthetic. Not only that, it is also used as an antiarrhythmic drug. It's an antiarrhythmic. Which class? Any ideas? Yes, you are right. Class 1B antiarrhythmic. So what does it block? Obviously sodium channels. Then we have a drug by the name bupivacaine. The name is bupivacaine, but specialty is it's most cardiotoxic. Most cardiotoxic, so avoid in intravenous regional anesthesia. So what happens intravenous regional anesthesia? What we do is we want to do local surgery in the arm. We inflate a cuff and we give the local anesthetic locally. So because the cuff is inflated, the drug is not going systemically, it will act locally. But bupivacaine is so much toxic, we don't want to give that in this intravenous regional anesthesia because even small amount can cause cardiotoxicity. So avoid in intravenous regional anesthesia. Then we have a drug called ropivacaine. It is used in labor analgesia. So nowadays there is a trend, painless labor. Nobody wants a pain. Then we can prefer what is that? Ropivacaine. Similarly, bupivacaine had cardiotoxicity. So recently we have come with levobupivacaine. The specialty is this is less cardiotoxic compared to the parent drug, that is bupivacaine. So these are the specialties of individual drugs. Now when we give local anesthesia, are there any factors that matter? Yeah. Let us understand what factors affect local anesthetic action. Factors affecting local anesthesia. Local anesthesia. Number 1, the plasma protein bound. You know the general pharmacology. If they are highly plasma protein bound, they are usually longer acting, you all know it. And if they are low plasma protein bound, they are obviously shorter acting. We know the general pharma. Second, lipid solubility. Second is lipid solubility. Obviously, because the axonal membrane is made up of the lipid myelin. So if the drugs are more lipid soluble, they increase the blockade. In nerve. So the blockade is increased if they are more lipid soluble. So increase in blockade. So lipid soluble means more nerve blockade and conduction can be blocked easily. Then important, this point is very, very important. Now what happens when you add addition of vasoconstrictor? Now most of you have seen lignocaine is given with adrenaline. Lignocaine is given with adrenaline. Adrenaline is a local vasoconstrictor here. Now the dilution ranges from 1 in 50,000 to 1 in 2 lakh. So that's the range. Sometimes it is used in 1 in 1 lakh, 1 in 80,000, 1 in 2 lakh. So the range for local anesthesia is, along with local anesthesia, is 1 in 50,000 to 2 lakh. Now the point here to understand, and most of your exam question is, what is the advantage of this? What is the advantage of this? Let us analyze. You only tell. Suppose I want to suture and the bleeding is coming. The blood is coming out, bleeding heavily. Then can I suture easily? No. So when I use a vasoconstrictor, the advantage is bleeding decreases. So the bloodless surgery can be done. And easily we can have a clear field of surgery. Second, lignocaine can get systemically absorbed. And if it gets absorbed, you know the problem, seizures, arrhythmia. So if I use a vasoconstrictor, it will stay there for a long time. So one is the duration of action of local anesthesia is prolonged. Second, the absorption of local anesthesia is also decreased. So what are the advantages? Local anesthesia acts longer locally. So locally it will work longer, so you can do the surgery and you will have decreased bleeding because of vasoconstrictor, so you will have bloodless field for surgery. Bloodless field for surgery. Very good. Right. Another important is less systemic absorption of local anesthesia. Now, if they are absorbed less, it's good only. The adverse effect will not be seen. But what is the disadvantage? What is the disadvantage? You only tell me. Disadvantage is what? Many a times adrenaline can also get absorbed locally. What happens if adrenaline gets inside? So it can increase the heart rate, it can increase the blood pressure. So importantly, remember, don't use this. This combination is contraindicated in a patient with ischemic heart disease. It can constrict the blood vessel and worsen it. If the patient has uncontrolled hypertension, don't use them. Or the patient is having left ventricular failure, those patients don't give adrenaline with local anesthesia. That is point number one. Point number two, suppose somebody had a cut on the finger, tip of the finger. If you use lignocaine with adrenaline, what happens? These tip of the finger don't have anastomosis. So what happens? They undergo vasoconstriction and there is ischemia and gangrene. So the tissues may die. So the combination should not be used in end arteries. So not used in end arteries. Not used in end arteries. So what are the places where there is end arteries? Avoid in tip of the fingers, toes. Suppose somebody has toe injury and if you start suturing that, he will lose the toe. Then tip of the nose. So again, there is a correlation between your anatomy and pharmacology. Then ear lobules, here they also have end arteries, and the penis. So why these are important? If you don't know this, somebody had a cut and you gave lignocaine with adrenaline, you are losing that finger, you are losing the toe, you are losing the tip of the nose. That's the reason why you should study anatomy and pharmacology, and all are integrated here. Now, suppose you have given lignocaine with adrenaline and you have done the suturing already and you want the anesthesia to be reversed. Is there any drug to reverse it? Why lignocaine is longer acting? Because you are given a vasoconstrictor. How to reverse it? Give a vasodilator, and the commonly used vasodilator to reverse that is called phentolamine. So if you want to reverse it faster, early, then we can use phentolamine for that. Okay, that is the point. The next important aspect we need to understand, what are the factors affecting local anesthesia, is a factor called inflammation. So will the inflammation affect the action of the drug is a question. Now inflammation is a place where the pH is acidic. The pH is acidic. Now what happens in the acidic pH? In the acidic pH, local anesthetics are basic and they are ionized. So in the acidic pH, local anesthetics are ionized. If they are ionized, they will not penetrate the tissue. They will not penetrate the tissue. And if they are ionized, there is decrease in local anesthetic activity. So what is the place where you see the inflammation? That is pus. So if somebody is having pus, you would have seen in your hospital, if they have pus and you want to drain the pus, if you give local anesthesia is not going to work. Why? Because the pus, the inflammatory site is acidic, and in acidic environment, local anesthetic remain ionized, and if they are ionized, they cannot cross the cell membrane and they will not work. So remember, at the place of pus, local anesthetics are not going to work. And also the acidic pH, there will be vasodilation. Why? Because inflammation causes vasodilation, and what happens if there is vasodilation? There is increased absorption of local anesthesia. So if local anesthetic absorption is increased, what happens? Duration of action is decreased. So inflammation, we have acidic pH, the local anesthetic is not going to work. Second, inflammation cause vasodilation, and local anesthetic, even if you give, they are absorbed into the systemic circulation. So this question may be asked in your exam: why local anesthetics are ineffective in the presence of pus? Very, very important. The next important aspect I just want to tell you is a concept of pKa, which we already discussed in general pharmacology. So what do you mean by pKa? pKa is the pH where the drug is 50% ionized and 50% non-ionized. Let me take an example of a drug by the name lignocaine. So lignocaine has a pKa value of 7.7. Another drug, bupivacaine, has a pKa value of 8.7. Now tell me, at the blood pH, so the blood pH is around 7.4. Now at this pH, who is more in the non-ionized form? Who is more in the non-ionized form? Let us check that. To check that, you should know the basics of pH and pK. We have a separate video for that. Watch it. Now this is a 0. Let me write the segment here. This is the 14. Now let me tell you the pK value is here. Suppose the pK value is 7.7. This is for lignocaine. This is for lignocaine. Now this side, it is acidic environment for the drug, and this side, it's basic environment for the drug. So here it is 50% ionized and 50% non-ionized. If you move a pH towards this side, left side, that is around 6.7. Now here it is an acidic environment because lignocaine, bupivacaine are basic drugs. So here 90% is ionized, 10% is non-ionized. So if you take the pH, what is the pH of the blood is around 7.4, you can see the drug is less than 50% non-ionized. So it is between 10 to 50%. This is the range. Now let us take the example of bupivacaine. Bupivacaine, let me write 0. This is 14. Now the pK of that is 8.7. Now for this side is acidic environment, this side is basic environment. Now if I shift a pH this side, 7.7 for bupivacaine, let me write this is for bupivacaine. Now 8.7 is a point where it is 50% non-ionized and 50% ionized. Now if you move towards a pH of 7.7, now how much is it? It is acidic environment, so it is around 10%. It is around 10% non-ionized, but 90% it is ionized. So more is ionized at a pH of 7.7. Now you take the example here. At a pH of 7.7, only 50% is ionized. So who is going to cross easily in the blood? It is the bupivacaine or lignocaine. Obviously lignocaine, because at the 7.7 pH it is 50% ionized and 50% non-ionized. If you take the example of bupivacaine, at the 7.7 pH 90% is ionized. That means they cannot cross easily. 10% only is non-ionized. So that's why who will have better permeability into the cell membrane and in the blood, it is the lignocaine. So the onset of action will be better for lignocaine, and that is the reason why the pK value is more important. Yes. So that is in brief for you. So the understanding is lignocaine has fast onset and bupivacaine has slow onset of action. That's it. So that is the importance of knowing the pK values. So we understood the various factors affecting local anesthetic effect: plasma protein binding, addition of vasoconstrictor, pKa value, lipid solubility, all these are important. So once I know this, is there any importance of drug interactions? Yes. I already told you the drug interaction between local anesthesia plus adrenaline. We have discussed that already. Now what about the lignocaine plus propranolol? A commonly asked drug interaction in exam. Now easy. Now lignocaine is metabolized by what? Metabolized by liver. So how does it reach the liver? The blood vessel has to send the lignocaine to the liver, so then it will get metabolized. So the blood flow is important, because you know that hepatic clearance is equal to hepatic blood flow into hepatic extraction ratio. So hepatic metabolism depends on blood flow to the liver. Now what happens when I use propranolol? Propranolol is a vasoconstrictor and decreases hepatic blood flow. What happens if I give lignocaine with propranolol? Lignocaine is not metabolized because the hepatic blood flow is decreased. So if you are giving them together, what is the message? Should I give the normal dose of lignocaine or decrease the dose? Obviously the metabolism decreases, so you have to decrease the dose of lignocaine. If you give normal dose, what happens? Lignocaine is metabolized by the liver, but metabolism will not occur because the blood flow decreases. So lignocaine toxicity can happen. So that's why you have to reduce the dose when you are using lignocaine and propranolol together. Very, very important. So the last thing we need to understand is uses of local anesthesia. Uses of local anesthesia. Yes, what are the uses? Now number one, they are used as antiarrhythmics, and I have discussed the main drug lignocaine. So remember that it's a class 1B antiarrhythmic. Procainamide is a class 1A antiarrhythmic. They are used as local anesthetics. Now what are the types of local anesthesia? There are different types of local anesthesia, I will tell you. Broadly, the anesthesia is called as surface anesthesia. Sir, what do you mean by surface anesthesia? Suppose you want to pass a Ryle's tube or a nasogastric tube. Suppose you take the tube and go like this, patient will not allow because there is sensation. So instead of that, we apply the local anesthetic and move it inside. The sensation will not be there. So that is called surface. We spray it locally to the throat. When you are passing catheter, that is called surface anesthesia. Another important anesthesia is called infiltration anesthesia. Infiltration anesthesia. Now what is infiltration anesthesia? Suppose there is a cut on the finger or on the wrist. What we do? We give the local anesthesia around that cut. So we infiltrate around the nerve. So that is infiltration anesthesia. Then we have something called the conduction block. So we have something called the conduction block. Now in conduction block we have two types. What are the two types? It is called the field block. It is called the field block, and one more is called the nerve block. One is called the field block, one more is called the nerve block. What do you mean by that? What do you understand by that? So let us understand like this. Suppose this is the nerve and it is giving the branches like this. Right? It is giving the branches like this. Okay. Now if I am giving the anesthetics here, this is called infiltration anesthesia. So we are infiltrating locally around certain branches of the nerve. Now if I am giving anesthesia here, this is called the field block. So if I am giving the anesthetic here, all the nerves coming at this point are blocked, so no sensation comes from this field. This field, no sensation comes. Or you can block it here itself, that is called nerve block. That is called nerve block. So these are the different types of local anesthesia we have. One is surface anesthesia, second one is infiltration, nerve block and field block. Okay. Now I told you the three types, but most important type we have is something called the spinal anesthesia. Spinal anesthesia is a local anesthesia. Now you remember this is the spinal cord and we have layers on that. So let me write the layer here. The first one is the pia mater, arachnoid and the dura mater. So this is the spinal cord. Now what we do is, when we are giving local anesthesia, we give it into the, let me write this is pia, arachnoid, dura mater. So when we pass the needle at the space of L2, L3, and here is the place where we inject local anesthesia, that is subarachnoid space. We give it in sub means below, arachnoid space. So that is the spinal anesthesia, usually at the level of L2, L3. Yes. Okay, so is there any complications of this spinal anesthesia? Yes, the patients may have problem of respiratory paralysis, the BP may fall, there is a chance of meningitis and headache can happen with this. So those things are dealt in detail in anesthesia. Then one more anesthesia is called epidural anesthesia. Epidural anesthesia. So what do you mean by epidural anesthesia? Let me write the same thing here. So we have the pia, arachnoid and dura mater. So here we are giving that upon the dura. Epidura means upon dura. This is the place where we inject local anesthesia, that is called epidural anesthesia. So I told you surface anesthesia, infiltration, nerve block, field block, and then spinal anesthesia and epidural anesthesia. So one more what we have is intravenous regional anesthesia. So we have intravenous regional anesthesia. What we do is we tie a BP cuff and we block the blood flow. We give the local anesthesia here and it will work only there. So once the procedure is done, we will release that and the anesthetic effect is gone. But remember, that is only for small procedures, small orthopedic procedures, but in this one drug is contraindicated and that is called bupivacaine because it is highly cardiotoxic drug. So never use it for intravenous regional anesthesia. So these are the types of local anesthetic procedures that will be dealt in detail in your anesthesia. So that is about local anesthesia, and we discussed local anesthesia. Number one, what is anesthesia? What is the difference between local and general anesthesia? Then I told you what is the difference between esters and amides. Esters are shorter acting, they have single eye, metabolized by esterases, they can cause hypersensitivity. Amides have two eye, less chance of hypersensitivity, and they are longer acting, metabolized by liver. Mechanism of action is local anesthetic block the sodium channels, particularly they block inactivated more than open state. And it's also important the pH and pKa. The non-ionized form is the one which can enter the axonal membrane and block the sodium channel. But once it enters, it again becomes ionized, and that ionized is going to block the sodium channel. Then we discussed what is the pharmacological actions, what are the sensations which are lost, what is going first and what is going last, and when we stop, what is going to reverse. Then in CNS, they can cause seizures. The first sign of neurological symptom of toxicity is circumoral numbness. In CVS, they can cause arrhythmias, they can decrease the BP except cocaine. Cocaine is a sympathetic, but it is called indirect sympathetic, which can increase the BP, heart rate, it can dilate the pupil. It's a drug of abuse. Then respiratory depressants. Local anesthetic overdose, we have an antidote that is called intralipid 20% emulsion. The mechanism is unknown. Then we discuss the factors affecting local anesthesia. Number one, the lipids are more lipid soluble, easy to start the action. High plastic protein binding, longer duration of action. inflammation, that is in the presence of pus, they are not effective. Then along with lignocaine with adrenaline, there is some advantage and disadvantage also. Don't give it in endarteries. Adrenaline is contraindicated if the patient has IST or left ventricular failure or he is having uncontrolled hypertension. Advantage, bloodless field for surgery. Local anesthetics act locally and they act for longer duration. Can we reverse it faster? Yes, by using vasodilator, that is called fentanyl. Then we discussed the individual drugs, their specialties, and then we discussed the types of anesthesia, that is local, surface, infiltration, conduction block, that is nerve block and field block, then spinal anesthesia, epidural anesthesia, and intravenous regional anesthesia. What is contraindicated as bupivacaine because it is highly cardiotoxic. So that is about local anesthetics. Thank you.